Everyone. It's with great pleasure that I introduce the next session called Coffee with Technologists. The coffee is already there. The technologist is here, so I need somebody to talk to. So for that, I'm going to introduce to you Dr. Manisha Singh, who is a consultant gynecologist at Fortis and head of the reproductive health. Dr. Manisha Singh is an eminent gynecologist and a subspecialist in reproductive medicine and surgery with over 17 years of extensive surgical experience. She has performed over 1,000 cycles of IVF and about 3,000 cases of ovulation induction successfully. She's been a meritorious and award-winning student, commenced her training in obstetrics and gynecology at KEM in 1991, and then was subsequently awarded the Doctorate of Medicine, followed by the award of DNB by the National Board of Exams, awarded the Royal College of London MRCOG in 1997, followed by CCST in 2005 with dual accreditation in reproductive medicine and surgery. She completed an MD in reproductive medicine from the University of Leeds in 2008. She's been working there for the last 17 years and recently moved back to India to take over as head of the department of Fortis. Dr. Manisha has been actively involved in both laboratory and clinical research in reproductive medicine and surgery, still continues to be involved in PCSOS and endometriosis research. She's a peer reviewer for several journals, has published in over 20 different reputed international journals, and has contributed significantly to the medical fraternity by presenting on various aspects of reproductive medicine and surgery. She has also authored many chapters on issues ranging from menstrual dysfunction, ART and gynecological ultrasound in the yearly periodicals for the general practitioners, postgraduates and undergraduate textbooks, and also was a tutor at the Royal College of Obstetrics and Gynecologists. She's an acknowledged expert in the advanced reproductive minimal access surgery. It's a great pleasure to have her with us today to share her thoughts. Please, Dr. Manisha, if you could come on stage.
Thanks.
Okay. So thank you very much for taking some time off from your really busy schedule and coming to talk to us. As you know, this is the Women in Technology Forum, and we have a number of technologists here. And as you asked me when I met you, there are men in the audience as well.
That's good.
So there are women and men. So to kick things off, how does a typical day look like for you? What is a typical day?
First of all, thanks for inviting me, and a very good afternoon to everybody. Being a working mother, my day starts at 5 in the morning. Get my kids organized for school, and then get myself organized to start my theatre session at 8. Start my clinic at about 10 and work until 4. Monday to Friday, and then because you guys are all free over the weekend, I have to work longer, so I work until 7, that's 11 hours on a Saturday, and I get a day off on Sunday, so to tidy up the house and get things done, so that's my working week.
Okay. So, having worked a long time outside India, you worked in the UK for a long time and you moved back to India. So, in your view, what are a couple of unique things which are unique about the Indian healthcare system as compared to the UK or the US, both in terms of your own specialization plus other observations that you have?
See, for me, I think I consider myself very fortunate. Because I did my basic training, my MD in Mumbai, India, in a very high volume center. So there was no dearth of hands-on experience. The volume of patients coming through the door is extensive. So when it comes to surgical skills, you are going to be a perfectionist at that because you've seen the complications, you've seen it, been there, done it. The one thing that goes missing when you do a huge volume of work is communication. And for that, I'm very, very happy that I went to the UK. And what I learned was that you actually need to talk to a patient who's a lay person, who doesn't understand your medical terminology, the science. You need to come down to absolutely basic level, spend some time, explain them, and help them make an informed choice about the management. In India, people tend to dictate management. You are told, you've got a fibroid, you need surgery. Thank you very much. And the patient says, fair enough, if you think that's what I need, I need. But there, it is not that. We give the patient 5 different options. The patient takes home information leaflets, which not everybody provides in India, because not a lot of people are literate. So if they're unable to read the information, they should at least be explained the information in their own language. Now, as a consultant in Manchester, I had 76 different link workers speaking 76 different languages. So whenever I saw a patient of any nationality and they didn't speak English, I had the link worker sitting in there explaining the exact logistics of what I was offering to do. And then they made an informed choice. So that is where we lag. And of course, the training that comes in with the specialty is slightly amiss in India. So you see one, do one, teach one in India. Whereas there you have to see, assist, and eventually when you are certified enough to be a good assistant, then you start doing things. And when you have done a given level of things, you are assessed objectively, independently by a panel, and then you are allowed to actually practice it. So you don't unleash someone on the population who's just seen one and done one.
Sure. What about disease patterns? Do you find anything unique?
UK now has a huge immigrant population from so many different countries. So you see lots of diseases in the UK now as well. But if you talk about India per se, I mean, particularly relevant to my specialty, see, about 50% women walking on the streets have polycystic ovaries. So I get a lot of patients who say, I've been diagnosed with PCOD. And I think because everybody's so internet savvy these days, they read. I'm not quite sure how much they understand, but the minute they see the word PCOD, they start jumping up and down about it. They think it's a disease process, but it's not actually a disease process. It's just a variant of normal. So you see a lot of PCO in the population. You may not see the whole syndrome, but you do see a lot of polycystic ovaries in the population. What I'm also finding since I've come to India, and I've been here for the last 7 months, is a lot of tuberculosis, genital tuberculosis, which is impacting on fertility. And of course, there are other issues like lifestyle. People work erratic hours, especially the IT sector and sector like this. They eat infrequently, they get takeaways, it's unhealthy. And there's a lot of weight issues, there's a lot of early hypertension, there's a lot of early diabetes. So you're not only just having to battle the main issue related to infertility, but you also have all these side things happening which you need to deal with simultaneously.
Right.
So that makes it a tiny bit more tricky.
Okay. So, you have about close to 200 technologies sitting in the room. So if you were to make a wish list of, 3 things that would make your life easier, on many of the challenges that you have said, what would they be?
My wish list is endless.
Okay. So.
But I think for me, the first important thing is that awareness is most important, and there is a lack of awareness. Whether it's a literate population or it's illiterate population, it doesn't matter. There's a lack of awareness. People tend to have their focus very skewed, and I think people need to get a checklist done pretty early, especially for women. I think it's pretty important. I'm seeing a lot of women coming late, for treatment. And then they say, I wish someone had said to me that fertility should have been dealt with earlier. I was too busy with my career. And I think sitting down and making a checklist of your priorities. And basically, I think everyone got to where they are today in this audience because they worked very hard, because they were focused, because they knew what they wanted. In the same way, say for example, you want to embark on fertility, don't put it on the side. Just ask yourself, how old am I? Is my fertility going to last forever? For men, it's different. For women, it's very, very different. All women have a very finite age when they're going to be very fertile, and then it starts declining. So you need to do that check. And then if you decide that fertility is what you want, then get that as your main focus and work towards it. Because without you working towards it as a couple, it ain't going to work. So that is another thing. For a place like GE Healthcare, you're a big, big company, very impressive campus, absolutely amazing. I'd like to see companies like yourself engaging doctors not just in big corporate hospitals, because you can sell your technology there, because they can buy all the expensive, impressive kit that you've got. I think you should reach out to the masses, because breast cancer just doesn't happen to the very elite, literate woman. It can happen to anybody. So you've got your digital mammography units and things like that. But how many doctors out there are trained?
Sure.
How can you subsidize this? So I'd like to see, big companies come out. See, the big thing in England for me was that the National Health Service provided patients with free health care.
Right.
Women got one IVF cycle at least on the NHS, if not more, An IVF cycle in England is typically about, 3,500 to 5,000 pounds. But the government made it available for the women there. What has our government done? If at all the government has to prioritize, it will prioritize for things like cancer, maybe heart disease. But does fertility come in on the wish list for the government? It does not. It comes very low. That's the problem.
That's the problem.
So the problem is not with the people who have the money.
Right.
The problem is with the general population who does not have that much money to afford even IVF in India, which is typically about, anywhere between 1 to 2 lakhs in India. So basically, people might say that India has a huge population, 1.2 billion, so why does India need more kids? But you need the younger generation for your economy anyway. And the people who suffer from that is a poor man,
Sure.
who doesn't have the money for his infertile status,
Right.
basically.
So it's a great point that you make of actually taking healthcare down to the rural areas, to tier 2, tier 3 cities, to the masses, as you put it. We do have a lot of initiatives on that direction. Of course, what we call the whole Health Imagination Initiative, which is focusing on cost, access, and quality for the different status. Also, several in India, in-country, for-country programs, which actually address this. But of course, there's a lot to be done. What are your thoughts on sort of public-private partnership in engaging government? Since you brought up the government, Fortis does a lot of work in that area.
I think, Fortis is a corporate hospital.
Sure.
So tomorrow, if you said to me that you want to link up with my unit,
Right.
that would be great, because what you can do is you could run camps, or you could have some kind of funding allocated to treating people who are not so affording,
Sure.
There are lots of government hospitals, but if you see, like for example, IVF, is it available to everybody?
Right.
It is not available to everybody. So maybe, a funding or health awareness camps, or maybe actually treatment camps or
Right.
diagnostic camps, things, that is how I see
Sure.
how you can build up a partnership, because you've got the technology, we've got the expertise, and I think linking that up together is a perfect way of getting out to the masses.
So this is supposed to be coffee with.
It's
so you
cold
please,
coffee now.
It's warm. I think we can try it out, but okay. So yeah, you're right. It is pretty cold. So I would suggest you try it. Okay. So moving on. What are the diagnostic equipment that you use in your area of expertise? Like
Scanning?
Scanning. Yeah.
Every day, day in, day out.
So what kind of
I can
equipment?
scan blindly now.
So what kind of equipment? Ultrasound?